So I welcome you all to the pre-Congress master class, and the theme for today is the technology, quality, and IVF. So our first lecture is on QC in conventional IVF. Can I get introduction of the speaker? Yeah. So our speaker is the senior embryologist, Dr. Bindu Chimote. She is MSc, MPhil, PhD in biochemistry, and she has done MSc clinical embryology from Leeds, UK. She is also a joint secretary IFS. She has presented various original research papers and also as a first author and as co-author for European Society of Human Reproduction and Embryo, for ASHRAE particularly, and for ASRM also. I'm sorry, I am not able to read clearly. Please excuse me for the, yeah, thank you. So she has won the best paper in travel training award at ASRM 2013 and best poster video award at ASRM 2019. She has published 8 original research papers in international peer-reviewed journals. And she is also reviewer of journals, mainly reproductive biology and endocrinology, and Journal of Assisted Reproduction and Genetics. She has contributed as 14 chapters to national and international books on infertility. She has also contributed an invited chapter in the prestigious Elsewhere book series named Vitamins and Hormones. Her major thrust area of research is follicular fluid metabolomics, endometrial receptivity, and reproductive endocrinology. Ma'am is also a member of ASHRAE, ASRM, IFS, ISAR, ACE, and NOGS. Over to you, ma'am.
Good afternoon, everyone, and many thanks, Dr. Devin, for the wonderful introduction. And I must say, I like the term embryology Olympics, really. And Dr. Gates, Dr. Sanjay Shukla sir, Dr. Charu Datta, Dr. Sanket, Dr. Rahul, I must say, you have already won the gold for the wonderful program that you have made for this event. I congratulate you and also wish you all the best for the 2-day event. I'm sure it is going to be an academic feast for everyone, and many thanks for inviting me over. Can I start with my slide? Can you all hear me?
Yes, ma'am. Start.
Yeah. Okay. So I'm really thankful that I've got this topic to speak on, because at a time when people are moving towards ICSI for all, this is something very dear to me. I mean, I still do conventional insemination, and it is really a wonderful talk to give on, especially for this masterclass. So, quality control in conventional insemination. So what are the things that we should do and we shouldn't do while doing conventional insemination? Well, whatever threshold values and KPIs that I have used comes from the Vienna Consensus Report, which included the ASHRAE SIG group on embryology as well as the alpha scientists in reproductive medicine. Okay, so undoubtedly, fertilization rate is among the most important KPIs that sets the benchmark for any IVF laboratory. And as you can see, I will not read out, but then it is the fertilization rate which sets the ball rolling, so to speak, because everything else after that, be it the cleavage rate on day 2 or the embryo development rate on day 2, day 3, the blastocyst formation rate, all are calculated in terms of the fertilization rate. And eventually, of course, therefore, the embryo implantation as well as the clinical pregnancy rate are dependent on the fertilization rate to begin with. And if you have a fertilization rate of more than 60%, that is the minimum competency that is reflected. But to set a benchmark, you should have a consistently good fertilization rate of more than 75%. That sets the benchmark. Now, how do we really follow this benchmark? How do we set this benchmark even with doing conventional insemination? So, what are the various factors that define the fertilization rate as such an important KPI? So, the Various factors are the intact oocyte rate, the normal fertilization rate, poor fertilization rate, multinucleation rate, single pronucleus rate, and zygote morphology. Now, if you can see here, I have given different colors. Now, just before we go into what is the quality control for conventional insemination, in brief, I would like to just differentiate between the conventional insemination as well as ICSI. So, the color scheme you will understand while we discuss further why I have given this colors. And okay, so coming to the first factor which defines the KPI for fertilization is the intact oocytes rate. You all will agree that when we are talking of conventional insemination versus ICSI, this factor is more relevant for ICSI because your oocyte damage rate or the oocyte lysis rate is very negligible in case of conventional insemination, while it is more in case of ICSI. So this KPI or this factor which defines the fertilization rate is taken care of when we do conventional insemination. So conventional insemination scores better, at least here, as compared to ICSI. Then why conventional insemination? Another factor is the abnormal fertilization when we talk about. For example, single pronuclear fertilization. So there was this wonderful paper by Palermo and group, the Palermo-Elicani-Cohen group, where they evaluated the chromosomal status of unipronuclear human zygotes following IVF and ICSI. And they found that the asynchronous PN appearance or entry of a sperm that did not decondense results in the single pronuclear fertilization. And they found that the risk of chromosomal anomalies or aneuploidy in cells with the single pronucleus was more in case of ICSI as compared to when we had done conventional insemination. So it is not that the abnormal fertilization occurs only more in conventional insemination, it could be in ICSI as well. Rather, there were only 9.5% diploid cells in ICSI, whereas 61.9% after IVF. So the single pronuclear fertilization rates also and the aneuploidy rates post such a fertilization pattern is the aneuploidy rate is more in ICSI as compared to conventional insemination, and therefore again conventional insemination scores better. Now then again talking about percent multinucleation. Now here again we need to differentiate between multinucleation and polyspermy. So what is polyspermy and what is multinucleation otherwise? So in IVF or conventional insemination, the reason for diandry can be due to entry of two sperms in the oocyte due to a high concentration of motile spermatozoa in the insemination volume. So polyspermy is one thing that could occur more in conventional insemination. But having said that, it is also seen that polyspermy may be the result of either oocyte maturity, that is the failure of cortical reaction to occur, or oocyte overmaturity. So the oocyte status, the immature status or the over maturity status may also dictate whether there is polyspermy occurring or not. So it is not the process of conventional insemination itself, but also the oocyte defect that could be a reason for polyspermy. And it is found that the incidence of polyspermy or more than 3 pn is about 4 to 7% in IVF, and the alpha survey says that anything less than 9% is reflects your competence, whereas less than 4.5% sets a benchmark. So conventional insemination is safe, so to speak, even with respect to polyspermy rate. Now, talking of other kinds of abnormal fertilization, where there could be an entry of a diploid sperm. This is very unlikely in conventional insemination, but it is more possible in case of ICSI. And chances of digyny are again more in ICSI than in conventional insemination. So diploid sperm. Now, why does this happen? More in ICSI, a very probable reason is that in conventional insemination we have a very natural selection or screening of the sperm that can enter. Whereas in ICSI, because we it gets subjective when we select the sperm. So we cannot be sure what we are picking, and therefore we could pick a diploid sperm for ICSI, but then the likelihood of a diploid sperm entering in case of conventional insemination is less. Similarly, chances of digyny are more in ICSI than in conventional insemination. Again, here a possible explanation for digyny is the failure of the extrusion of the second polar body, or non-disjunction as we would call it. And this is the most common reason for the presence of 3 pronuclei after ICSI. This is again a report given by Penisser in human reproduction. So again, the drawbacks that we usually think that conventional insemination could have actually does not have any of those drawbacks. Similarly, finally, when we talk of the zygote morphology scoring, we all are aware how there is the Z1, Z2, Z3, and Z4 scoring, depending upon how the pronuclei are placed with respect to one another and how the nuclear precursor bodies are placed. So, with respect to the zygote scoring or pronuclear scoring, again, there was a report about the predictive value of pronuclear morphology screening on embryo development and pregnancy outcomes in ART cycles, or should we say the pattern of fertilization on the effect of pattern of fertilization on embryo development. And it was found again that the Z1 score, which is considered the best score, was higher in case of conventional insemination compared to ICSI, and so also all other instances, or at least we can safely say that there is no significant difference between IVF and ICSI as regards the pronuclear scoring is concerned. Rather, in some cases, conventional insemination stands or scores better as compared to ICSI. So again, in terms of this, the overall embryo fertilization pattern, conventional insemination is safe or seems to score better. And therefore, now coming to the quality control. Having said that, the picture is clear in our mind that whether we do ICSI or insemination, the very fact that the KPI defines the fertilization rate for conventional insemination as well as ICSI a similar rate. So that itself defeats the purpose when people say that ICSI at least ensures fertilization. When your KPI says it is similar, more than 75% is the benchmark, whether it is conventional insemination or ICSI, means that you cannot say that ICSI scores higher in terms of fertilization rates. So now, having said that, what are the things that we should keep in mind when doing conventional insemination? So we have to take care of polyspermy and certain other factors when we do ICSI, when we do conventional insemination. So what is our quality control at the first level? Here I would say that patient deselection. I wouldn't say selection, because selection then we can actually do conventional insemination in most of the circumstances. So patient deselection for conventional insemination. So obviously male factor. Now what are those factors? So if it is a severe oligoasthenoteratozoospermia where you have low sperm number, motility as well as morphology, the morphology again defined as per Tiger's strict criteria, then in that case obviously we would try to refrain from doing a conventional insemination. But then if it is just a low sperm number, or say a borderline, just the sperm number is about say even 15, but it has a very good motility, grade 4 motility, which is in excess of 75%, then even in that case, just the low sperm number, but the motility is good and morphology is also good, then you can still go in for conventional insemination. So by itself, just the sperm number, or by itself, just the morphology does not dictate selection of ICSI. Rather, you can go ahead with conventional insemination. Of course, with surgically retrieved sperm, we would not do conventional insemination. Similarly, retrograde ejaculation or a complete globozoospermia sample, where again, if we, we will not do conventional insemination with globozoospermia, and a sample with a high antibody titer. Now, a high antibody titer in the sense there's a lot of infection there. there are people who would say that, okay, we would, by washing, we would take care of all the infection and we can still go ahead, but then you never know in such cases how much the DNA fragmentation has occurred, and therefore you would be really skeptical about doing a conventional insemination with a high antibody titer, because you do not want contamination in your dish. Now, certain factors about the male, certain things about the male factor, which people usually do not consider conventional insemination, is the frozen sperm sample. Now, I personally, I have a simple logic or reason that if we can do IUI with a donor frozen sperm sample, why can't we do conventional insemination? And of course, I have done quite a few conventional insemination with a frozen sperm sample also, with fantastic results, with no compromise in the fertilization rates. So yes, even with the frozen sperm sample, you of course, but then you have to take care that in such a case, after thawing, you give it a wash, so that you wash off all any cryoprotectant that could be present there, and post wash you just evaluate once again the count and motility of the sample before you go ahead with your conventional insemination. So yes, even with the frozen sperm sample, you can go ahead after washing without compromising the fertilization rates. Then there is something called, of course, we all say, have been saying that if you are doing the PGD or the screening for genetic diseases, then in that case, we would prefer to go in for ICSI. But then there was this very interesting paper in 2020 where they compared aneuploidy rates between conventional IVF and ICSI. And they try to compare what is the outcome when we do where PGD has been recommended and you do conventional insemination and ICSI. And they found that it is unlikely that conventional IVF caused significant contamination during PGTA, and therefore they recommended that conventional IVF as the preferred insemination method in PGTA cycles, and ICSI should be indicated only in cases of male factor infertility. So here again, this PGTA where we have been propagating the use of ICSI, even in those cases, conventional insemination can be done. However, you have to take care that you wash the oocytes properly post insemination and before the third check, so that there are no remnants of the sperm present over there, and no sperm sticking to the zona pellucidis. And finally, the third is the pre and post wash DFI. Now, this is a very dicey issue. We say that a sperm with a sample with a high DFI, we should go for ICSI. Now, if you're just doing ICSI without any further selection method, then again, I don't see any reason why how conventional insemination is different from ICSI, even in cases of high DFI, because at least in conventional insemination, there is natural selection, and therefore you can say safely that even with a high DFI, there won't be any harmful effects, so to speak. But now, since we have the sperm selection methods like the sperm sorting, where specifically the sperm with high DFI is sorted out and you get supposedly a sample with low DFI, then in that case, either going for, do not select conventional insemination, or you use that sperm sorter, and if the count and motility are otherwise good, then that sorted sperm can be used again for even a sample with high DFI by using a sperm sorter, and therefore supposedly collecting a sperm sample with low DFI, you can go ahead with conventional insemination if the yield post sorting is good. So that was about the quality control for male factor. Now coming to the patient deselection for female factor. Under what circumstances will you not go for conventional insemination is when you have several failed IUI cycle even with a normal male factor, or previous poor fertilization or total fertilization failure after IVF, where there could also be occult male factor or oocyte activation failure. So in that case, it would be safe not to do conventional insemination. Also, advanced maternal age, where the zona probably could be thick, and therefore if there is a previous cycle with poor failed fertilization, then you would like like to go in for ICSI rather than conventional insemination. And of course, the frozen thawed oocytes, obviously, because they have been denuded before freezing, and therefore you would not go in for conventional insemination. So these are the two cases, a couple of cases where you would not go for conventional insemination. Also, now, patient deselection for conventional insemination, you have to be in a good rapport with your clinician as regards the stimulation protocol as well. Now, if there is an asynchronized cohort of follicles and stimulation, that is, it is indicative of different levels of nuclear maturation. Now, why does this occur? There is an because of difference in the nuclear maturation and so also the cytoplasmic maturation. There is an inactivation of maturation promoting factor necessary for the oocyte to complete meiosis and enter the G1 stage. Now, if there is an asynchronized cohort of follicles, then this maturation promoting factor remains activated, and therefore the oocyte remains arrested at the N2 stage, leading to premature chromatin condensation. And this PCC may result in poor fertilization or TFF. And therefore, if there is a high degree of asynchronized cohort of follicles after stimulation, then you might consider not doing conventional insemination, because then that would affect your fertilization rates. Now, PCC is often associated. What kind of a stimulation protocol is often does it result in the asynchronous cohort of follicles? Is CC and HMG protocol of stimulation, where in most cases when people do a batch IVF and they do use HMG protocol, in that cases, if there is an
Last 1 minute remaining.
Oh my God, there is a lot that I have to speak. Okay, dose and duration of gonadotropins may also affect the oocyte maturity and hamper the fertilization. Similarly, now in some, this is again a tricky question, whether patients with endometriosis, would you like to go for insemination or ICSI? My personal experience says that since in endometriosis, there are fragile oocytes and there is an amorphous cytoplasm, lot of dark central granulation. Therefore, it would be better to go in for insemination, because if you do ICSI, there is more of oocyte damage to, there's more of oocyte damage and lysis if you do ICSI, and therefore, I would like to go in for insemination even in cases where there is tuberculosis or endometriosis. Then, coming to a major factor, that is sperm preparation and handling, because here you have to take care of two major things. One, that is you do not want the polyspermy occurring, and also you do not want any contamination happening. So rule out any chances of contamination or occult or symptomatic, that is the genitourinary infection. Take care that the patient has been treated with enough with antibiotics and antioxidant treatment. And the preferred method of sperm preparation are swim up and direct hairing. Density gradient, again, a lot of people do only density gradient for their IVF protocols. But then here, while doing this, you have to take care that don't throw the supernatant and then resuspend the pellet in the same centrifuge tube. Rather, you pick up the pellet and transfer it into a fresh tube and then resuspend it, so that, because when you just try to dispose of the supernatant, then in that case what you are doing is actually allowing that debris to again accumulate over the pellet, and it still remains. So a lot of debris still remains along with the pellet if you resuspend in the same tube, and this may lead to contamination in your inseminate. And therefore, pick the pellet and resuspend in fresh tube. After washing, do not let the sample lying at 37 degrees. At most places, I've seen that after preparation and there is still 2 hours remaining and they let it remain. So what you are doing in the process is you are allowing the capacitation reaction to occur, and therefore there will be low fertilization rates if the sample has
Can you
remained
please finish?
Yeah, quickly, just 2 minutes.
Time is already over.
I know. So just heat at 37 for 5 to 10 minutes. Only before use, otherwise keep the sample at room temperature after preparation. Then the timing of insemination, usually it is 2 to 6 hours post OPU, because if it is at less than 2 hours, then there are issues with cytoplasmic maturation, and if it is more than 6 hours, there could be spindle instability and scattering of chromosomes. But then I would suggest, rather than timing of OPU, you decide more about focus more on the timing of trigger, and it is usually 37 to 42 hours post trigger that you do your insemination. And of course, you have to optimize in consent with your clinician how they have monitored the follicle and what is their criteria for giving the timing for trigger. Then sperm concentrate or volume, usually it is 1 million per ml of for co-incubation of 5 COCs, and 12 to 15 microliters if you're putting 8 to 10 COCs in a particular dish. Again, it also depends on the drop size and the number of oocytes per drop. If you are using a central well dish with 0.5 ml of media and putting 10 COCs, about 15 microliters of a sample is good enough for insemination. Or if you are doing in microdrops of 100 microliters, 3 COCs and 5 microliters of your sample, and you place your oocytes well so that there is proper interaction between the gametes. Finally, the cumulus manipulation, you just try to loosen the cumulus. Don't remove, of course, don't minute, but loosen the cumulus, remove any blood clot or granulosa cells if they are attached, because they are, the blood clots are known to hamper the fertilization rates. And coming to pH, temperature, osmolality, you have to follow the manufacturer's instructions while equilibrating your media. You have to prepare your dish at room temperature, or a cold surface, not the heated surface. And also, yes, and the most important thing is you have to maintain the temperature that is from pickup to your stage, and then keeping in the incubator throughout. You have to maintain 37 degrees centigrade. So take care that even at the source of oocyte pickup till the tube reaches you, there are stage warmers where the oocytes in tubes at 37 degrees centigrade are transferred to you, and then you carry on the further process. You need to wash the oocytes. Usually I do it with a follicular aspirate, the original follicular aspirate, followed by in the buffer, first in the outer moat of the central well, and then in the central well, and then shift immediately to the fertilization dish. Minimize the handling time and exposure time to prevent any changes in temperature, pH and osmolality. And finally, preventing the harmful effects of ROS. There are papers which have suggested that it takes just about 1 to 3 hours for the sperm to enter, and for the second polar body to be discharged, it takes about less than 5 hours. So after 5 hours of insemination, you can safely clean the oocytes of the sperm and transfer into a fresh dish, so that there is no ROS buildup because of the presence of sperm, or even if there is you have done conventional insemination with endometriosis patients. In such cases, washing the oocytes after 5 to 6 hours post insemination can help in giving you better fertilization rates, even with conventional insemination. So that's it. Thank you so much for your patient listening, and I'm sorry if I exceeded the time limit. I have
Okay, thank you, ma'am, for the detailed presentation. But as we have run out of time, I think we will not be able to take any questions for now.
Okay.
Yeah, over to the organizers, please.
Yeah. I thank Dr. Bindu Chimote, ma'am, and Dr. Devin Patel, sir. Ma'am, it was a highly insightful presentation.